Good afternoon, folks. Thank you for being with us. We apologize for a little start that's late here. Had a little weather issues going on. Everybody's running around different directions, and we're probably going to have folks coming in and dropping out during the afternoon because there's a lot of other meetings going on. But we wanted to just take this opportunity to have the department come over, and we felt like it was important that they could be here and sort of do what I've sort of called Medicaid 101, for lack of a better name of this, but just really to be able to try to provide some information maybe for some folks who may not be as familiar with this. And unless you've dealt with it, you probably haven't had any occasion to be, unless you're as old as some of us and we know about Medicare a little bit and things like that. But really, we're glad to have you here and glad to be up here with our cohort over in the Senate, Senator Golden. You want to have a word or two? You could? Okay. Well, what we're going to do, we're going to open up and we'll turn it over to the commissioner, let him make his opening remarks, and then when he does that, I think he has some department folks that'll be making other presentations. And then what our intent is, when they get through making their presentations, and y'all should have one of these slide presentations. They've had some more. Didn't know exactly how many to make, but if you need one, we'll get it for you. And then when they finish up, we'll have some time for questions toward the end there to do that. Now, the commissioner will make his remarks, and then he's going to have to excuse himself. He's got some other meetings he needs to be attending, which is just fine. So with that, Commissioner, we're glad to have you and the department over here to talk with us today, and look forward to hearing from you.
Members of the General Assembly, I want to thank you all for taking some time to be here today to talk about a very important program in the state of Georgia, Medicaid. Chairman Parrish and Chairman Goldman, let me just give a particular thanks to both of you for allowing this opportunity to talk about the basics of the Medicaid program, which is such an important part of our healthcare infrastructure in the state here. As you all know, the Medicaid program is a joint federal and state program with about 2/3 of the funding coming from Washington, D.C. Medicaid is a very large program. It is the third largest payer of health care in the country. And on the state level, Medicaid is one of the largest programs that we have here in the state. It provides health care coverage to about 1 in 5 Georgians and consumes about 17% of the state's budget. So I think it's important to learn about it and pay some attention to it. As I mentioned, Medicaid is a critical piece of our infrastructure here, and that's frankly why we're so grateful for this opportunity to come and share with you a little bit about the basics of the program. We wanted to talk about what Medicaid is, who is eligible, who provides care, and what kind of care. I think you may be surprised at the different kinds of care that Medicaid provides. We also wanted to provide some context for that, some historical information about Medicaid and how it's different from a lot of the other health care programs that are out there, how it's funded, and primarily to make ourselves available to answer any questions that you all might have. I want to acknowledge a couple people. First, let me point out Jesse Wethington. If you don't know Jesse, raise your hand, Jesse. Jesse is the Director of Government Affairs for the department. He's down here every day. If you have any questions, he's our key contact person. My Deputy Commissioner, Blake Fullenwider, is also down here very regularly. And both of these gentlemen are available to you should you have any questions. Also, let me introduce some other folks on our staff here. Is that Jerry Dubberly? Okay, I couldn't quite see. Dr. Dubberly is a pharmacist. He is the director of the Medicaid program. Blake and Jesse and Dr. Dubberly will be making some presentations in a minute. As a constant resource is our Chief Financial Officer, Vince Harris, and our Director of Communications, Chris Shrimp. And the man who runs a lot of numbers for us, Kevin Tomlick, and we're glad that you're here with us today, too. So we've got a good team here, very proud of this team. I think we can answer most questions that you have, and if we can't answer them, we'll certainly get those answers to you, and let me just encourage you to ask questions.
Commissioner, before you get in,
sure.
Let me stop this a minute. There's some folks who are having to stand in the back. If you don't have some seats back there, why don't y'all fill in on the sides over here, and just as long as we kind of leave the front for the senators and representatives, but we hate for you guys to have to stand up back there. So if y'all will just make yourself comfortable and fill in over there.
Thank you, Mr. Chairman. Yeah, I was encouraging y'all to ask questions, and we do that. These fellows here can tell you on a daily basis I'm constantly asking questions of them and learning more about what is a very complicated system. One of the questions that I get asked on a regular basis are, what are the biggest issues you see facing the Medicaid program? And I would have to answer that with two basic issues, and I don't think we're unique in that in Georgia here. My counterparts across the country, I think, raise the same issues. The first big concern I've got with the Medicaid program is sustaining the program at both the state and the federal level. And Blake Fullenwider is going to talk a little bit about the history and the context of that and in just a minute. The second issue I would raise would be the lack of flexibility. And let me just speak a little bit about that, because some of the other issues are all going to be covered by the rest of the team here. But one of the things that has surprised me the most in terms of leading DCH in the Medicaid program is that we don't really have a lot of flexibility within that program. Much of what we do is mandated by the federal government. Much of how we do it is mandated by the federal government. Eligibility and scope of benefits are currently restricted under maintenance of effort requirements in the federal law. And then when we look at other ways to manage the program, utilization and price, anything that we do there requires some kind of an amendment or a waiver to our state plan. So I've been commissioner for 22 months. In that 22 months, we have filed 31 waivers or amendments to our plan. So it's a little bit more than one per month. So Medicaid, as you go into it and you try to manage this program, which Blake will talk about some of the historical context, the options for managing it become quite limited. We have continued, along with our sister states, I think virtually every governor in the state has asked for more flexibility in the Medicaid program, and I know that there is a large amount of concern over sustaining it from a fiscal basis. But I talk about the flexibility issue here just for a minute to kind of prepare you for some of the thoughts and questions and ideas you might have going forward through the rest of the meeting here today. And you may say, well, why do you do this and why can't we do that? A large part of those answers are going to be because we're restricted by federal rule or regulation in order to do what we do. But that should not stop us from asking the questions, and it shouldn't stop us from looking for every single way that we can manage the program better and better serve the citizens of the state. So let me just once again thank you, both Mr. Chairman and for having this meeting today, and I will turn it over to Blake, who will take it from here. Thanks.
Thank you, Commissioner, Chairman Parrish, Chairman Golden. Good afternoon. Members of the General Assembly, good afternoon. As the Commissioner mentioned, I'm going to provide a quick historical overview of Medicaid since its inception to where we are today. I'm not going to make this a history lecture, I promise, so we'll try to move through this quickly so that we can get to some other material about the Georgia Medicaid program. First, to start, I think it's important to always to clarify two words that sometimes can be used interchangeably, and that is Medicare and Medicaid. I think it's important to recognize there are some key differences in what these are and who they serve. Medicare is entirely federal and is administered by the U.S. Department of Health and Human Services, and speaking in the most general terms, Medicare is available to individuals who are age 65 or over and who have paid into the system via payroll taxes for 40 quarters or 10 years. Individuals with end-stage renal disease, kidney failure, also become eligible if regular dialysis or kidney transplants are needed. Now, that's an overly simplistic, of course, generalization of what Medicare is, but since our focus is on Medicaid and CHIP, we'll move forward and get into more detail on those two programs. Medicaid is a state-run program that many folks don't realize is actually optional. States have the federal government does not require states to operate Medicaid programs, but as we all know, they provide substantial funding for states to do that. Today, every state in the country does operate a Medicaid program, although the time in which they entered the system and the degree to the coverage that they provide varies widely from state to state. In Georgia, Medicaid provides health coverage to low-income as well as age-blind and disabled Georgians. The low-income individuals primarily covered are pregnant women and children. The State Children's Health Insurance Program, or as in Georgia we call Peach Care for Kids, is a newer program, and this was established by Congress under the Balanced Budget Act of 1997 signed by President Clinton. This law is to provide coverage to children who are not eligible for Medicaid but don't have access to private insurance. Generally, a family's income, household income, would make them ineligible for Medicaid, so this provides a similar benefit for those children and children only in that area. Moving to the next slide is a little historical context since the inception of the program in 1965. Over the time, the program has evolved and it's grown and grown through both state and federal actions to where we are today. Now, this isn't an exhaustive list of all the things and the changes that have occurred since its creation, but these are some of the key things, particularly those that we've seen in recent years. Again, Medicaid and Medicare was established in 1965, and again, the CHIP program was established in 1997. One of the key things that's occurred recently was the Deficit Reduction Act of 2005. This was a budget reconciliation measure taken up by the United States Congress, and the budget reconciliation instructions for the Energy and Commerce Committee that has jurisdiction over the Medicaid program was to come up with $20 billion in savings over 10 years. $10 billion of that was to be found in health care programs, so some key policy and programmatic changes were adopted at that time, most of which were enacted in 2006. One of the provisions that DRA enacted in 2006 was a requirement that individuals enrolling into Medicaid or CHIP must satisfactorily document and verify their citizenship and identity for enrollment into the program. Now, prior to 2006, 46 states and the District of Columbia accepted an unverified self-attestation that an individual is a U.S. citizen or a certain category of legal permanent resident and is therefore eligible for the program. That was a dramatic change in the way that the programs are operated on a state-by-state basis. Georgia did adopt that slightly before the federal rules did kick in on July 1st of 2006. And I would note that Governor Deal actually, when he was the chairman of the Health Subcommittee of Energy and Commerce, authored and passed this language during his tenure in Congress. Now, moving on to 2010, the Affordable Care Act passed and mandated that as a condition of receiving any Medicaid funding for a state, states must expand their coverage levels to 138% of the federal poverty level or risk losing all of their federal share for the program. Now, in 2012, last June, the Supreme Court's ruling was a little bit different than a lot of the pundits had expected. The focus was on the individual mandate and the constitutionality thereof, citing the Commerce Clause and other reasons why it was against the Constitution for the Congress to force someone to buy insurance. Now, the courts didn't find that the unconstitutional piece of the law. They instead proclaimed that as a tax, but they did take a look at the forced Medicaid expansion that was written into the Affordable Care Act. Chief Justice Roberts put it pretty clearly when he said that forcing states to expand their Medicaid rolls to 138% of the federal poverty level was akin to a gun to the head of states. That's pretty strong language. The net effect of that is it's made the expansion of Medicaid in all states an option for the state to elect to take up or not, and there's no time frame or deadline for making that election. Now, to take a look historically in terms of just healthcare spending in general, you'll note here the light blue wedge at the bottom of the graph represents Medicare, the darker blue being that of Medicaid, and then you've got all other health care, which would be self-pay, private coverage, and other. As you can see here, federal and state expenditures have steadily increased, both in absolute terms and as fractions of national output or GDP. To put some numbers to it, in 1966, total Medicaid spending, both federal and state, was approximately $1.3 billion, representing about 1/5 of 1% of GDP. In 2010, Medicaid outlays totaled $401.4 billion, or approximately 2.8% of GDP. Per capita health spending has increased at a rate approximately 2% faster than national output for decades. Now, to take another look at Medicaid spending growth, and this chart will highlight the countercyclical nature of the program itself. As you can see from this chart, for years 1968 to 2010, Medicaid spending growth has outpaced the national output by an overwhelming majority of the program's history, meaning that Medicaid will continue to consume a larger portion of the nation's resources if this trend continues. Like I mentioned on the countercyclical nature of the program, as spending rises dramatically Medicaid spending rises dramatically in lean economic times. You can note the spikes in 1991, 2001, and 2009, where we saw times of economic downturn. In fact, year on year, Medicaid spending has only decreased a single year in the program's 46-year history. That was in 2006 at the height of the housing bubble. Several key cost containment provisions of the DRA, as I mentioned, also took effect in that year. Now, this is a per capita spending growth view of the Medicaid program over time since its inception. The takeaway here is, in real per capita terms, total Medicaid and CHIP spending increased from about $6 per person in 1966 to about $1,388 today. Here's another national view of Medicaid growth over time. In 1966, the program enrolled about 4 million people, representing about 2% of the population. Cost was about $1.3 billion, and that represented about 1/2 of 1% of GDP. You can see the tremendous growth over time, and I'll just note a couple here. By 2010, in 2010, Medicaid nationally had 54 million enrollees, about 17% of our total population, representing $401 billion in expenditures. It's about 2.7% of GDP. Projections for 2020 have just been released. They actually came out in August by CBO after the ruling on the Supreme Court case. These revised budget and economic forecasts assume that several states will opt out of the Medicaid expansion. And as you can see, CBO projects that we will add an additional 31 million people to the Medicaid rolls by the end of this decade. CBO also projects that the Medicaid costs are expected to more than double this decade alone. Now we'll take this down to a Georgia view. You can see in 2000 we had just shy of about 950,000 enrollees in the program, or about 11% of the population. That represented about $1.3 billion in state funds, or about 10.2% of state revenue. In 2009, that enrolled population grew to about 1.4 million people, or about 15% of the population, representing about $2.4 billion in state funds and about 15% of state revenues. Projections for 2019 estimate enrollment at 1.8 million, about 15% of the state population, with about $3.8 billion in state investment, or about 17% of our state revenues. So this is how much it costs, and where do we compare in Georgia to the national trends. Here's a focus from fiscal year 2003 to today. So the question is, how does the growth in Medicaid costs compare to national trends? You can see from this slide that we continue to be under the national trend for Medicare expenditure growth. Medicaid expenditures have grown 19% from FY08 to FY12. During this same period, the national growth trend for Medicaid was about 31%. With the introduction of government-provided health programs such as Medicare and Medicaid, the fund source, that is where the dollars are coming from into the healthcare system, has dramatically changed. You can see this as a comparison from 1960 to 2009. Where we are today is now a situation where public spending accounts for nearly half of the national output consumed by health goods and services and is primarily directed towards providing actual health care benefits. One thing this chart doesn't include is the $300 billion annual subsidies for employer-sponsored insurance resulting from the favorable tax treatment for employers who provide that coverage. That's not factored into this, but I think the overall takeaway is pretty dramatic where you can see the dollars are coming from. Now, having provided the committee with some basic historical context to show you how Medicaid has grown over its 46-year life, I'll now turn it over to Jesse, who will discuss the basics of the program and how it functions in Georgia. Jesse?
Thank you for the introduction, Blake. Thank you again, Mr. Chairman, for presenting us with the opportunity to present and speak with the committee and the members today. While we're preparing for today's presentation, I struggled to think of some common overarching theme that I could bring forward as an illustrative point to underscore the program and help the committee and the members here today to understand it. I quickly gave up on that, but I was able to arrive at one generalizable statement, and that is it is very difficult to make a generalizable statement about the Medicaid program. As I have found working to resolve many of the constituent cases that your offices send to me, there is a waiver, variance, or exception to nearly every rule and regulation in Medicaid, and seemingly there are hundreds of pages of these issued almost every day. If anyone tells you that they are an expert and fully understand the program, with the possible exception of Dr. Dubberly, they may be pulling your leg. The vast scope and scale of what the program does is mind-boggling. As the Commissioner mentioned in his budget briefings to the Joint Committee and the Subcommittee, Georgia Medicaid alone spends more than $31 million per day and processes or pays approximately 200,000 claims per day. Many of you are familiar with the topics that we're going to cover here today. We're not going to make anyone an expert in Medicaid. Rather, we hope to build on a base of understanding that can be built upon later. But even without the aid of an overarching theme for our presentation, we will endeavor to avoid slipping into jargon or Mandarin. That being said, a particular piece of jargon serves to illustrate a key point. DCH is referred to within federal and state law as the single state agency for Medicaid, meaning that DCH is the touch point between the state and federal government for Medicaid. However, that term can be misleading. Although often described as a joint federal-state program that provides health insurance benefits to the needy or disabled, it is also a program that operates in concert with other agencies of the state government, namely the Department of Behavioral Health and Developmental Disabilities, the Department of Public Health, the Department of Human Services, Department of Education, Department of Juvenile Justice, and also local entities such as schools, community service boards, and county health departments play a role in service delivery for our members. At whatever level, one common theme runs through the universe of Medicaid, and that is the use of acronyms. This alphabet soup of agencies administers the program in Georgia. DCH is responsible for the overall operation, regulation, and funding of the program. DBHDD administers 3 of our Medicaid waiver programs, and the DBHDD budget contains the state matching dollars used to draw down federal funding for mental health, addictive disease, and developmental disability services. Each county board of health is an enrolled Medicaid provider, and many of our members receive critical safety net, population health, or maternal health services at their county health department through programs like Planning for Healthy Babies or Babies Can't Wait. And finally, the Department of Family and Children Services of the Department of Human Services is the entry point for citizens into the Medicaid system. Members will apply for Medicaid benefits or a disability determination at their local county DFACS office. This second helping of acronyms barely scratches the surface of those that we use commonly in the program, but this set covers those that are most often used in the shorthand that you'll hear us when we use when we are referring to the program. Mastering these will go a long way in understanding budget documents or policy briefs on our subject. If you'll permit me, Chairman, I will briefly define each of these and then try not to use them for the remainder of the presentation. ABD is age blind disabled. That refers to our fee-for-service Medicaid program that treats the people who fall into those categories of age blind or disabled. LIM, or low-income Medicaid, is our care management program, primarily for pregnant women, babies, and those with new children, young children. SCHIP, as Blake mentioned, is the State Children's Health Insurance Program, or in Georgia we call it Peach Care for Kids. CMO, or MCO, refers to a care management organization. These are the private insurance companies that we contract with to administer the low-income Medicaid program. Fee-for-service refers to the financial reimbursement methodology used in the Age Blind and Disabled program, meaning that when an individual goes in to receive services that are covered by Medicaid, they'll generate a claim. That claim will be paid based on a schedule of fees established largely by the federal government or with the state, and based on a Medicare fee schedule. MMIS is the Medicaid Management Information System. That is the fiscal agent that we refer to that pays and processes our claims. PPACA is the Patient Protection and Affordable Care Act. I'll try to use ACA henceforth in the presentation. The next two can be confusing. HIX refers to a health insurance exchange. Those are the marketplaces envisioned in the Affordable Care Act, whereby an individual would go and receive a subsidy for the purchase of a health insurance product, or alternately be determined to be eligible for public assistance, such as Medicaid. And an HIE is a health information exchange. This is a quasi-governmental program in Georgia. We have an entity called the Georgia Health Information Exchange, Inc., and they seek to facilitate connections between regional private health information exchanges to facilitate the exchange of patients' protected health information between providers so that we can take some of the paper and waste out of the health system. Moving on, FPL refers to federal poverty level. That is a percentage of a family's income based on their family size, and it's used to determine the eligibility for various portions of the program. FFP is federal financial participation. That is the federal government's contribution to the state's Medicaid programs. FMAP refers to the federal medical assistance percentage. That is the ratio of federal to state dollars present in Medicaid programs. Those range from 50%, I think, at the lowest, whereas the federal government splits the cost of a state Medicaid program with that state's government. And I believe the highest range is up in the neighborhood of 78, 80%. For lower income states. And finally, HCBS refers to home and community-based services. These are services that are provided, as it sounds, in the home or in the community for our members who would otherwise be receiving care in an institution. This concept is both used to promote, moving people out of institutional settings to comply with something called the Olmstead Agreement, which is a Supreme Court decision that originated from a case here in Georgia, as well as the nature of the services and where they're delivered. So first I will again treat on Medicare just for a moment, run through parts A through D so that we can again sort of see the distinction between the state's Medicaid program and the federal government's Medicare. Medicare Part A is the hospital insurance program that's funded through the HI Trust Fund, which you will see deducted in your payroll taxes. Part B is the professional services component. It also covers things like durable medical equipment that are not covered under Part A. Part C refers to Medicare Advantage plans. These are private HMOs that receive subsidy and compete for customers within the Medicare program, and they provide wraparound services or additional benefits that are not provided on traditional Medicare. And Part D is the prescription drug benefit, which was enacted in 2003 to cover prescription drugs. My office gets many constituent calls that are related to Medicare. Unfortunately, we must refer those constituents to a representative of the federal government for help. Medicare and Medicaid are, again, distinct programs, albeit with many, many touch points that are too complex to cover in detail today. And we have gone through parts A through D. So now I will stop discussing Medicare after treating on the dual eligible population and move on to Medicaid. A dual eligible member is someone who is covered by both Medicare and Medicaid. Medicaid covers a portion of their costs that are not borne by Medicare, and those differ depending on your socioeconomic status, income level, or health status. And the duals are some of the most acute cases and most expensive cases that we treat. There's been some movement towards additional coordination with the federal government. There's an Office of Dual Eligible Coordination within the federal Medicare agency now, and so we will see what the future holds for the dual eligibles. The issue is coordination between the state and federal governments of their disparate benefits, which I don't think any state has found the magic bullet to solve the problem of the duals yet. Moving on to Medicaid proper. Medicaid is governed by Title 19 of the Social Security Act, Title 49 of the Official Code of Georgia, a contractual agreement with the federal government called the state plan, as well as relevant case law. Medicaid is a federal entitlement, and Title 19 funds are mandatory appropriations of Congress, meaning this amount of annual spending is not determined by an appropriations bill, rather formulaically. Individuals qualify by falling in a defined class, usually including a means test, but also including citizenship and income verification, as Blake mentioned. Others will qualify by virtue of a health condition or disability. So first, we'll talk about the aged, blind, and disabled component of Georgia's Medicaid program. It is bifurcated into two distinct halves, as I've said. The traditional fee-for-service program is referred to as aged, blind, and disabled, or ABD. And this program is directly administered by the Department of Community Health. In ABD, we use what is termed a fiscal agent, as I mentioned, to process and pay claims. This is the MMIS, and it is currently managed by HP EDS. ABD works on an any willing provider model, meaning any provider who is qualified to participate is allowed to do so, and the members may freely choose between those different service providers. And we refer to ABD as unmanaged, meaning that there is no care coordination or utilization management of a significant kind. Next, I'll treat on some of our waivers. Now, waiver is a term with a dual meaning in the Medicaid context, which can lead to some confusion. First, a state can apply for a waiver, and this is what the Commissioner was referring to in his opening remarks, that is subject to approval by the federal government. If it is approved, the Center for Medicare and Medicaid Services will waive a relevant portion of the Social Security Act to allow a state to experiment with different methodologies or service delivery models, as long as those can be demonstrated to be cost neutral to the federal government. Now, an individual can qualify for a Medicaid, what we term waiver, which to receive coverage or services that may not normally be entitled to receive. And this next slide gives you an overview of Georgia's waiver programs. This table shows active Medicaid programs that are we refer to as waivers in Georgia, as well as their active membership, the relationship to DCH and our sister agencies. Note if you have a constituent that is applying for the NowComp, CBAY, NowComp or the CBAY programs, you would need to contact the Department of Behavioral Health and Developmental Disabilities rather than DCH. Similarly, the Community Care Services program is administered by the Division of Aging Services within the Department of Human Services, so they would be the touch point for that program as well. I should also mention an item that is not on this list, that is the Katie Beckett or TEFRA waiver. It is not a waiver per se, but rather a waiving of the means test for children who are severely disabled and would otherwise be receiving care in an institutional setting. There are approximately 3,200 children receiving the Katie Beckett waiver today. Moving on to low-income Medicaid, or the LIM program as we refer to it. This is a means-tested insurance benefit, and its eligibility for this is determined as a percentage of your family's income on federal poverty level, again, dependent on the number of members in your household. This is primarily pregnant women, new mothers, infants, and young children, and it is administered by our 3 care management organizations via contract. In Georgia, those are WellCare, Peach State Health Plan, which is a subsidiary of the Centene Corporation, and AmeriGroup, which is owned by WellPoint. And the difference between this and the age, blind, and disabled program is primarily in the reimbursement methodology. This program is capitated. We pay a fixed per member per month cost for the CMOs to manage the care of the members who are assigned to them, and they are held at risk for managing that member's care. When a new member comes onto the program, they have a month to elect a CMO, which will provide their coverage and be the face of Medicaid to that patient. As indicated, the three CMOs operating are WellCare, Peach State, and AmeriGroup. Now that we've covered the basic elements of each of the Medicaid program, or the what, let's move into the who. This chart shows the different thresholds of eligibility for each category of assistance, which means the different patient classes that make up our Medicaid population. There are 27 distinct categories of service. They're not all listed here. Note that this does not include the Medicaid expansion as envisioned under the Patient Protection and Affordable Care Act, which would open low-income Medicaid to to childless adults who you see are not covered under the program today, with a modified adjusted gross income of 138% of the federal poverty level, as Blake mentioned. So who are our members? We have 1.7 million members average, which represents 17.8% of the state's population. The vast majority of these are children under the age of 18, and 42% of Georgia's children are covered by Medicaid or S-CHIP. So this is a graphical depiction of our membership. The pink bars represent females and the blue bars represent males, and they're broken into age bands. As you can see, children do comprise the overwhelming majority of our members. As the Commissioner stated in his budget presentation, Medicaid and Peach Care for Kids are responsible for the care, again, out of four out of 10 children in the state. How much does it cost? This is the DCH 2013 state funds budget. The Medicaid program is found in the red and blue segments of the pie chart. S-CHIP, or Peach Care for Kids, is the yellow sliver. As you can see, it is a minuscule amount of funding compared to age blind and disabled or low income. And for reference, the state health benefit plan, with its 640,000 members, is represented in green. DCH has a $12 billion budget. You can see from the pie chart that Medicaid accounts for about 2/3 of that, or $7.8 billion in total funds. It includes our two halves of the program, and we've already referenced benefit plan. This is a breakdown of cost per member per year by age band. Excuse me, I'll have to get this a little bit closer to read it. If you can see the per member per year cost on the far right-hand side of the chart, you see where really the expense drivers for the program are. They are not children, but rather those aged 45 to 64 years or aged 85 years and up. These are more of our complex cases, or they're receiving care in institutional settings, again, which are much more expensive. The children that you have covered on our programs, Medicaid and Peach Care, are low cost compared to the age blind and disabled population. So who's providing care? As the Commissioner mentioned, we have a wide array of providers that serve our patients. These are the top 5 categories of service represented by the amount of spending that they represent. In Medicaid, those are fairly evenly split. You can see the CMO capitation payments, which may be somewhat misleading because those would include the complete range of services received by our CMO membership in the low-income Medicaid program. So that represents approximately 36% of the spend in Medicaid, the remainder being rounded out with inpatient hospital services, skilled nursing facilities or nursing homes, pharmacy costs, and then outpatient hospital procedures. You'll see a similar type experience in Peach Care for Kids. We track more than 35 different provider types, and our members are served by approximately 77,000 providers, from acute care general hospitals and nursing homes to physicians, nurses, physicians' assistants, home health agencies, therapists, and many other types of healthcare provider setting or service that you could imagine would be medically necessary. This is a comparison for the cost and enrollment for the age blind and disabled and low-income Medicaid programs. As you can see, the age blind and disabled population comprises 29% of our population, but consumes 58% of our spending, whereas the low-income Medicaid population represents much more of our enrolled members and a far, far smaller claim on the total dollars spent. So this is another representation of cost, and those of you who saw the Commissioner's budget presentation should be familiar with this. The per member per year cost in Georgia in 2011 was $5,387. That compares favorably with some of our sister states in the southern region. This study is from the Council of State Governments. It illustrates that Georgia continues to have lower per member per year cost than our other states, Alabama being 18.5% higher than Georgia's per member per year spend, North Carolina being 51.5% higher. That does not mean that we are a terrible payer. In fact, Georgia, as in terms of physician services, we reimburse at 20% above the national average, which does compare favorably with some of our sister states as well. So having covered in broad strokes some of the basics of the program, we would now like to share with you some tidbits on the future direction of the program. So I would like to turn it over to Dr. Dubberly to give you an update on our Medicaid redesign effort. Thank you.
Thanks, Jesse. I do want to talk to you about some fun stuff. So we've gone through mechanics here. I want to talk about some very exciting prospects for the future. We have, under Commissioner Cook's leadership, undertaken a large effort to take a close look at our Medicaid program, to look at what's working, what's not working. And we've looked at it not only from the inside, but from the outside as well. You may know we've done a number of stakeholder forums. We did 30 throughout the state, geographically dispersed. We've also engaged sister agencies, legislators, current vendors, future vendors, everybody we can possibly think of. We also engaged a number of other states to have a number of different Medicaid models and CHIP programs in place, and engaged them in discussions about what's working in their state and what's not. We could collectively refer to this project as the Medicaid redesign. When we set forth with this program, we wanted to do three major goals. Our three major goals were that we wanted to improve outcomes for our patients, we wanted to achieve long-term sustainable savings, and we wanted to ensure appropriate utilization of services. So what I want to talk to you about now is just an update as to where we are with a couple of the efforts that have come out of that review. So we'll start with the age-blind disabled. As Jesse mentioned, largely our program has an age-blind disabled program and a low-income Medicaid or LIM program. With the age-blind disabled program, we heard consistently that what providers needed, what individuals needed, was better coordination of care. They needed assistance with navigating the Medicaid program. They needed individuals who could help them put together the services and access the services that they truly needed. So our approach that we have developed and we are working on now is partnering with a single statewide vendor that will assist us with this challenge. What we envision is no change to the payment mechanisms, all payments still through a fee-for-service program, payments from DCH through our current vendor, so no disruption there. But we have to have coordination of care. We have to have individuals who are resources who are monitoring our high acuity members, our highly impactable members, our high utilization members. Through that case management, disease management, and care coordination effort, we think we can greatly impact the quality of care that the individuals are receiving and the outcomes, as well as have a positive fiscal outcome. We do think that our members need to be connected to a medical home. So a patient-centered medical home is a term you may have heard a lot about. There's actually an NCQA recognition of patient-centered medical homes. We want to move toward that model. We recognize that there are relatively few of those NCQA-recognized medical homes in the state, but we want to incentivize and encourage our providers to move toward that. At a minimum, we want to make sure that our members have a medical home. We also are looking to make sure that, we had an old program that you may have heard of, the Georgia Better Healthcare Program. It was what we call a primary care case management, or PCCM model. Largely, there was a payment to a physician who had agreed to be the medical home for that member and coordinate care. We did cancel that program. It wasn't effective. We didn't have it properly aligned, and the outcomes were not there that we were seeking to achieve. We do think that in a larger program with other elements that our primary care case management model would be successful. So we're looking to incorporate that model here, where a physician engages to be the medical home, and there's a financial recognition for their role that they play in the care and the coordination for that member. That has to be demonstrated by outcomes, which brings us really to the value-based purchasing. There has to be an upside for the provider, so we're building what that actually looks like. If we get the outcomes we need, there would be an upside for the provider as well as for the vendor. Provider engagement is another bullet you see here on the slide. That's one of the things that in our previous attempts we didn't do a great job of. We procured a vendor, we tasked them to do certain things, but we didn't really give them all the tools that they needed. So we're looking to do that differently. Okay. So the next, we can go back, Kevin. So I guess I went a little out of order there. Okay. So what I have here on the slide is just some of what we heard from the providers and the stakeholders whenever we went out to meet with them. We kept hearing, put physicians back in the driver's seat. We need better care coordination for individuals who are high intensity. We need to make sure that whatever partner DCH procures or joins with to do this, there has to be strong oversight. We really took these, all of these points very seriously and have created a matrix such that as we develop the program, we're trying to define how exactly have we met these and where does that reside in the program. So if something's not working, we'll be able to go back and correct that. Okay, sorry. So next I want to talk about the next large effort that came out of our redesign so far, and that is the transition of children in foster care and adoption assistance into risk-based managed care, or the Georgia Families Program. And I know we're using a lot of terms that are interchangeable. Georgia Families is the actual title of the CMO or MCO model that Jesse referenced earlier during the alphabet soup. What we are moving forward with here is partnering with a single statewide CMO, care management organization, to take care of the provision of the medical services for the children. We consistently found that children in foster care needed greater medical oversight. We've had DFACs at the table with us who have consistently said, help us find ways to have better health outcomes for these children that are in our care. And so we've been very tightly partnered with the Department of Family and Children's Services as we've gone through this review. Our goal is really to improve the medical oversight and the outcomes for the individuals. We want to better coordinate care. As we've talked to DFACs and learned that some of the children who are in foster care through adolescence, it's not uncommon for them to have up to 16 different placements. And as they move from placement to placement, as you can imagine, the loss of continuity in their medical care, their medical records, and the knowledge base that the receiving family may start with when that child comes into their home is something that can be greatly improved. What we do think that will help with that is a portable health record that follows that patient, so that that family receiving that child does have access to all of the information that's available regarding the child's previous health care. We also think we can do a better job with preventive screenings. Children in foster care have lower preventive screenings than where they should be according to the national standards for preventive screening for any child. Behavioral health conditions, it's not surprising that children in foster care have a greater incidence of behavioral health needs. We've seen national data regarding the use of powerful atypical antipsychotics, for example, in children. A lot of questions as to what the appropriateness of that has been. One of the things that this project has really done is helped bring sister agencies together. When we really started looking at the landscape of all the different agencies that touch children, all of the different agencies that have a responsibility, we really had to take a close look and realize that we really aren't that well connected. We really don't communicate that well, and we don't always understand each other that well. So the outcome of this has been an interagency work group that has just been phenomenal. We have DCH, DBHD, DFACS, DJJ, Department of Education. We just have a number of different entities that, as we talk, we said, yeah, we need to connect with a certain entity or agency. As such, we have a better understanding of the needs of the different agencies. I looked at one sister agency system that they use to demonstrate medical oversight, and when we look at the medical component of the file, I'm saying, wow, I have all of this information that I can get to you, that you can have a better complete picture of the child and their medical history. And that can help with a better medical oversight as you're trying to take care of the needs of that child. Likewise, they have information that we need. We can look to see how the child is doing from their education plan, their health plan. Are there contributing factors that need to be better coordinated? So it's actually a very exciting partnership that we have put together. I also wanted to, as a primer, I wanted to make sure that there are certain things that you have assurances about. And one of the things I wanted to talk about was provider and member protections in our current CMO contracts. This comes up quite a bit, and through our stakeholder forums and our task forces, we had a provider task force, and the providers had very positive feedback and wanted to really make sure we were helping them with getting the word out as to what protections are in our current contracts for our members and our providers. I'm sure your constituents may ask you questions. I just want you to go into that discussion with the understanding that there are some assurances in place that are meant to protect those parties. Okay. So, stay there. So I'm not going to read these to you. You have the handouts. This is more for you to refer back to, but I'll briefly go over some of these. Our CMOs cannot just adjust rates. They have to give notice, and they have to give an option for providers to be aware that that change is coming and take action to exit the network. Early on, we had concerns that rates were being changed. Providers were getting a fax saying, effective tomorrow, your rate is being reduced. Check here if you wish to disenroll. That's simply not acceptable, so we corrected that contractually, so the proper notice has to be given. We also made sure that we have protections in place so that plans cannot require participation in another program that they own. So if CMO ABC has our Medicaid CMO, but they also have a Medicare plan, participation in one can't be contingent upon participation in the other one. We also require a weekly payment cycle run so that providers are paid timely, that there's not a holding of funds to get the float out of the funds that are due to the provider. So those are paid every day. Notification of changes to claims and coding procedures and guidelines have to have 90-day notice. And providers have to have due process. There has to be an appeal process if a provider has been denied entry into the network for the plan. Continuing on provider protections, there also has to be a provider complaint system with turnaround times for responses, and those records have to be available to us and our vendors who do audits upon inspections. There are also minimum system response times that we have in place, so the systems have to be responsive to the providers who are depending upon those. One of the things that I'm most proud of is this one. We often found that our CMOs were referencing in their contracts per DCH policy. But then we often had a disagreement between the provider and the CMO as to what DCH policy truly said. So this language was added to say that DCH's interpretation of the language is final. We found where DCH and the CMO didn't always agree as to what the DCH language said. So our word is final there. I want to talk a little bit about quality protections. And I just want to make sure that we pat ourselves on the back when we're due. We take our hits when they're due. But Georgia has been recognized nationally by Secretary Sebelius as with our adoption of quality metrics, infusion into our program, and our attempts to influence those and build certain features into our program based upon quality. I just want you to know that we do have contractual language holding our CMO providers accountable for outcomes. We want to make sure that as individuals are admitted to an institution, that discharge planning starts upon admission to the institution, that discharge planning and coordination of care have to begin at that point. Members have freedom of choice to choose a primary care physician, don't have to have cause, they can change providers upon their request. Our members need to have the flexibility to do that. We also have contractual requirements regarding how long that a participating provider would have to get a member in to receive care if they called for an appointment. If a member can't get in timely, there really isn't access. And if there's not access, our CMO cannot claim that provider as part of their network that meets the access standards. Again, I'm going to, in the interest of time, move through some of these. It's really meant to make sure that you have some of these in place. I'm going to go to the quality protection slide here. I kind of jumped ahead a little bit, but just very proud of the fact that we have instilled quality into our program. Our plans are accountable for 34 standard HEDIS NCQA measures. They're held contractually accountable for those, and there are 9 performance improvement plans or projects that they have to implement to improve quality and to improve the service that they deliver each year. Okay. And with that, I'll just move on to a few examples. Sometimes we hear the bad, but we don't hear the good. And granted, there's good and bad in everything. But for the good, I want to mention that in our 13 report, which was based upon calendar year 12, we were able to demonstrate that CMOs had increased access to primary care for children in the first 2 years of life, that preventive care for the individuals that were 20 really to 64 years of age had to increase access to preventive care services. We had an improvement in our annual dental visits for our children. Well-child visits increased, which as did immunizations and screenings. We also saw a decrease in low birth weight babies that were born in our program. The next slide here with BMI, we've introduced the requirement that children, as part of their visit, have to have a BMI screening. And we saw that the first year that we implemented this, which was 2012, we had a 44% increase in BMI screenings for the children who had well-child visits. We also saw an increase in those children who were receiving nutrition and physical activity counseling as well. We also saw increases in breast cancer screening and STD screening. On the next slide, you'll see some hemoglobin A1C. I couldn't resist alphabet soup there, Jesse, sorry. But that's really control of the blood sugar. And so control of blood sugar, control of cholesterol, as well as blood pressure control. We saw improvements in all those measures. We also saw an improvement in the follow-up to children who had been receiving anti-ADHD meds for attention deficit hyperactivity disorder, making sure that once a prescription was written that they got back in within a certain number of days for follow-up care and for evaluation. And we also saw an improvement in the evaluation and return visits for individuals who had been discharged from a hospitalization for purposes of mental illness. So those are a few of the highlights that I wanted to mention just about the current program and where we're going from here. At this point, I think we'll turn it back over, and Jesse's going to moderate on our side in terms of who gets the question.
Okay, thank you for a lot of good information. And I'm sure there must be some questions out there. If you will put your light on, I'll try as best I can to recognize you in the order that I see them. Let's see here. Whoops. Right over here. Senator Say, I think it is. C, excuse me.
Thank you, Mr. Chairman. I'm asking as a follow-up to reimbursements from providers. I had a provider, and I think you may have gotten the inquiry, because 11 was bad, but 12 was horrible. We are still seeing reimbursements from October 12 that just came in January. Can you speak to what's going on with Peach State and why that is happening?
Vince, you want to field that one? Jerry.
Can I ask for what type provider are you referring to?
Speech and language.
Speech and language. I can't really speak truly for Peach State, but I can let you know that they've had significant issues with a vendor that's responsible for therapy services. I can let you know that today I received a notice of termination of that vendor, and they've outlined a plan for ensuring that the provider payments are current and accurate. So it's unfortunate. We have been monitoring that closely, and I think that we've reached an appropriate resolution.
Thank you. One follow-up. So what's the time frame if I'm asked to get back with you all in terms of, I'm hearing today that is a termination, but obviously small businesses can't stay in practice if they're not being reimbursed because they still have to, pay staff. So I'm trying to make sure that I can do everything I can do to assist. So you tell me, when should I follow up with you on a resolution?
The communication that I've had from the plan is that all payments would be current within 30 days. And so I expect that to be much quicker, but that's what I've been assured, that within 30 days.
Okay, so with you, if that hadn't occurred, because 12,
yes.
All of 12, it was always 30 days for the provider.
Yeah,
okay.
Please follow up with me if that doesn't occur.
Thank you.
Jesse, the ABD, we have an any willing provider plan set up, but we don't have that in the LIM. Is there a reason for that, or could we move to an any willing provider clause in LIM?
Sorry, sir. I think one of the methods that we're able to save the state money or avoid cost growth in LIM is by allowing the private CMOs to manage their networks at arm's length. That is, rather than having the state have to do the contracting administration, we think that that would probably impair our ability to control costs in the LIM program, I think is a basic reply to that, sir.
So we're controlling costs by preventing providers from participating?
That is one of the components of the low-income Medicaid program that allows us to control costs and sort of define what it will be for, the intermediate future.
I know you didn't make that decision, Jesse.
No, sir.
Thank you.
Just to follow up on Dr. Hawkins, I mean, what kind of evidence do we have that it is actually, given the savings that we had hoped for and the same quality same quality of care?
Just to touch on a few of those, from a quality perspective, we did go back and look at the experience within fee-for-service of the LIM population, pre and post managed care. Saw a clear difference. There was clear improvement with the CMOs. On our website, we publish our historical quality measures year by year, and what we see consistently is not only do the CMOs continue to have some improvement in the quality measures, but when we throw the fee-for-service population in there, there's clearly an inequity on some of the things that should be equal, whether the population is LIM or ABD. So you would expect ABD to have a higher acuity, sicker population, tougher to manage, but there are things like children in ABD who should still have their well-child visits, regardless as to their level of illness. So I think from a quality standpoint, we have a very nice picture that we've improved quality and we've improved outcomes. In terms of the financial side, we use this method where we looked at what would the cost have been in 2007 versus what they were in 2005, so the year before, the year after. So that those calculations and those presentations that we've done on that show that at least over that period from 2007 to last year, we're about $500 million in savings, not including the quality incentive fee, which went away. So as we get further and further away from our baseline of 2005, I just want to be honest, those numbers get less and less reliable. So it's really hard for me to continue to use that methodology, but we certainly have seen demonstrated savings.
May I follow up? So in that, did you factor in the additional staff that you needed to hire to oversee the CMOs?
Well, the reality is that we actually have maintained pretty consistent staffing levels since 2006. What we did is really kind of change some of the functions that people were doing and morph that into the oversight and other activities that came along with the CMO. We pretty much stay around in the Medicaid division itself about 120 staff members, and that's very consistent with prior to the CMOs.
Thank you all for putting this together, and thank you for being here. Is it true that we still have about a year and a half or 24 months or so before we're eligible to, or potentially eligible for any state plan waivers to be accepted or considered in Washington?
I think that would depend on the waiver type.
Are there any types that might be available now?
We continue to apply for waivers on a regular basis and state plan amendments. What we're not allowed any flexibility on is the scope of benefits or the maintenance of effort on who is eligible and at what level.
Just a follow-up, is that true for Medicaid as well as Peach Care? Or
I'm sorry, sir?
Is that true for Medicaid as well as Peach Care?
Yes, sir.
Thank you.
Thank you, Mr. Chairman. I had a couple of questions, and they're in different areas. One had to do with a particular problem. I represent a very rural district, and I was contacted by our urology group because in completing forms, they could not guarantee they could see a patient within your minimum. As they are my doctor, and I don't always get to see them as quickly as I want to. I want to say it was like 30 days or 28 days or something they had to guarantee to see the patient. As a result, their contract was lost. The patients now have to drive 60 miles to Albany to see a urologist. This is not practical. It doesn't make good sense. And that is a concern for me, and I don't know, is that something that has to be a waiver? Or is that something we can approve?
I assume that provider was terminated from a CMO network.
Yes.
We would at that point evaluate whether or not there was a violation of what we call their geo-access requirement.
Okay.
If that was an undue burden on the members to have to travel for that service, I think at that point we would.
I think they did something on an individual basis for a patient, but it just, again, needs to be some kind of flexibility there to represent rural areas. It just does not make common sense. My other issue has to do, if that's okay to ask another area, we all like to see that the claims are paid promptly, and to hear that doctors aren't paid with a timely basis is a great concern. They're not reimbursed what they're entitled to begin with, and I understand that. But on the opposite side of that coin, there are those that programs like this, as large as they are, have problems with fraud and abuse. I've read and studied a lot about it, and I know that Medicare recently divulged that they had been using a lot of pay and chase. Now that is something that is not acceptable, and I feel like, are we implementing something to keep from paying and chasing? Do we audit the claims before they go out? The best way to keep the money is, or to recover it, is to never pay it. And again, if we're waiting 3 months to pay a claim, I want to make sure it's a clean claim, it's a due claim, and that certain fields of care seem to be more prevalent to have fraud, duplicating, upcoding, things like that. And do you have a special unit or body that does check and audit these things? Because it is where a lot of money is wasted.
Absolutely, we do. Our program integrity unit is a separate division within the agency. The Inspector General is Mr. Robert Finlayson. He's former law enforcement in Cobb County, and he's been in that role for a number of years now. They actually had what we refer to as a bumper year last year in terms of recoveries. I think they set a record amount north of about $35 million. I do believe, do we use contingency fee audits still? Now, in certain categories of service, we do use contingency fees for our audits. I think we would need to follow up with you to give you what those were specifically.
Thank you. I appreciate knowing that.
Yes, ma'am.
I got a couple of questions. Have you all ran any models about how much money it would save the state if we moved the ABD into under the care of a CMO management? Can you share those numbers with you? And then I have another question.
Yes, sir. As part of the Medicaid redesign component, we had our team of consultants as well as actuaries who we use their services quite frequently, as you may imagine, run the numbers on different versions of what an expansion of managed care would look like prior to sort of the governor calling a halt to wholesale changes to Medicaid last year. The full bore managed care proposal was conservatively projected to save $1.2 billion over 5 years. That analysis was done by Aon Hewitt.
Okay. The other is the governor has called for a 5% cut. How is that going to affect the cost areas on your graph on page 27? Can you kind of discuss where those cuts will be?
Absolutely. Vince, do you want to field that one?
If you look closely at the budget document, you'll see that DCH was not able to identify a full 3% in 13 and 5% in 14. And it was due to the fact that we've been working for probably the past 3 to 5 years, cutting back where we could, and we just couldn't find and couldn't work quickly enough to identify the amount of savings that we needed to achieve. So we were able to do that in admin, but not in the benefits section.
So it's mostly coming out.
Well, yeah, I think it was $2 or $3 million in admin, which usually our admin is a 50-50 split. So that's really about let's see, for $2 million, it would be $4 million total funds out of our admin budget. Does that help? I mean, does that help a little bit? Okay.
Thank you, Mr. Chairman. My question has to do with the foster care assistance program that you are doing. First of all, let me thank you for being forward-thinking and along those lines. But I was curious as to what will foster parents actually get when they get a new child to come into their home. They don't know anything about them. And I've unfortunately had the experience of taking a child to a doctor and they ask about stuff. I don't know anything. I just know the child's sick. So what will they get in terms of instructions or preparation for the health status of the children when they come?
So the actual instructions that go to the family, of course, will come from DFACS, but I can tell you that our discussions that we've had is that with us building this patient health record and with DFACS being the parent and having access to that, when a child is received in the home, part of that package will be, here's the access to the child's medical record. And that will be that patient health record that will follow them. Part of what I didn't talk about but is very exciting is the informatics that will be available also on the provider side. Today I can go to my desk and I can look up any Medicaid member that I have a reason to and see their utilization and see what services they're receiving and from whom and in what quantities. But a provider who's actually providing the service does not have that information. They have the history that the patient tells them, and they have the history of what services that they provided. So we've taken advantage of some 90-10 funding from the federal government, and we're building a portal that providers will have access to, where they will be able to see the patient history. So they will be able to see what that patient's history is. They will also be able to see beyond just foster care, but we're starting with foster care, so that it doesn't matter if a child's in fee-for-service or foster care or CMO A, B, or C, they will have a complete picture. And as if that child moves from fee-for-service to CMO A to CMO B, they'll be able to see that view of what that child's utilization is. So in terms of the instructions, they'll get access with the child to their patient health record, but they'll also be complementing that, the information that the provider will have as well.
And one follow-up question, well, what happens when the children age out of foster care? What happens to that? Do they get that portable medical record then for themselves, or what?
Absolutely. The record will follow the child. I mean, it will follow the child into adulthood as long as they maintain that. I was recently had the privilege of going to D.C. and to a foster care presentation or panel that brought together folks from across the country. And they had a panel of, and I'm sorry I'm editorializing here, but they had a panel of foster care alumni. And consistently, the adults who were in the foster care system as children talked about the lack of access to health information, what was going on with them, where was their choice, where were they in the conversation. So this is also a huge consumerism tool that we think will bring a lot of value to that child long term as well.
Thank you, Mr. Chairman. I was just curious, when we look at the list of providers that the CMOs have, are our state health care facilities included on that CMO list of providers?
I would think there would be no reason that they would be excluded, but again, the CMOs manage their networks independently. Is there a mandate that they be included in the network?
They have to include FQHC.
So some public facilities, like for federally qualified health centers, are mandated to be in the network. And again, their reimbursement rates are set by the federal government as well, and so that's more of a provider class that is treated as sort of hands-off by the state government. The federal government determines a lot of the policies and reimbursement methodology for them.
If I could just follow up, I've had a couple of constituents with foster care children that wanted to use like a state mental health facility that was very close to where they lived, and they said that they were not included in the CMOs. So I sure would like to see as many of them as possible included so we can support our own entities, if that could be.
Certainly. I think afterwards we'll follow up and see if we can't find some arrangement for those individuals.
I want to just make a statement, then we'll have a question. They're not going to be the same. I just want to go back to CMOs. I know that we've seen savings, but let me tell you from the provider side what we really see. We see provider cuts that legislators are not aware of, and we see reduction of procedures. And when you start reducing procedures that we can do on patients, you have such a narrow band that outcomes may look better. But let me tell you, for some folks, the outcomes are not better. That's my statement. Now, the question is, how about FMAP? Are we hearing anything, getting any indication that we may see FMAP percentages go down in the future or near future?
Certainly. If you look at the current FMAP that's come out for 2013 is not, I think it has gone up by a fraction of a percentage point. There's proposals circulating around Washington in regards to the deficit reduction talks about moving to a blended FMAP. That's been a part of the president's proposed budget in 2013. Of course, that was not enacted. So that would be a potential cut. Additionally, we're also hearing that there may be, that places in jeopardy some of the 100% or 90% federal match envisioned in the Affordable Care Act. Before that even comes out, some of those may be off the table as part of an effort to reduce the federal deficit.
Say that again. I'm sorry, I didn't.
If you're talking about just the federal dollars for Medicaid expansion under the Affordable Care Act, there's been some indication that there could be a reduction in the 100% or 90% in some of the proposals around the president's budget.
Yeah, even if they didn't reduce the 100%, if they keep their word on the 100%, if they reduce that FMAP, it hits us across the board. Not even on the new enrollees, but the enrollees we have now.
Absolutely.
And we're in deep trouble.
And another cause for concern is even if the state does not expand Medicaid as envisioned under the Affordable Care Act, there are still a number of people who are in the state today who are eligible for our current program who may not be enrolled today for whatever reason. We feel like when the individual mandate is enacted, those people will come in and that will be at the lower FMAP, not the expansion FMAP.
Right. Okay. Thank you.
That's all the lights that I see as far as questions. I don't want to generate questions, but we don't want to overlook someone. So I think you guys have done a great job. Like I said, they've given us a lot of good information, and we've sort of worn everybody out, I think. But I want to thank Blake and Jess and Vince and Kevin and certainly the Commissioner for coming over today. I think this has been beneficial, and we'll thank our colleagues in the House and in the Senate for coming. Hopefully we've all gotten some good information and understand this a bit better, and just appreciate y'all being here. Thanks to y'all. We're going to take a break for a few minutes, and at 4 o'clock we're going to have the Department of Public Health do their budget presentation to our House subcommittee, so we'll hold up till then.